Welcome to Dr. Sam's anatomy classes once again. We are back here to solve this anatomy question paper of Atal Bihari Vajpayee Medical University of Uttar Pradesh. You must have watched the previous video that was on paper 1 that included part 1 and part 2 of paper 1. So if you've watched this video, they have solved all the MCQs and have given a brief description about all the short and long questions that have been asked earlier. So this was paper 1 part 1 and now this is paper 1 part 2. So both these papers have been solved earlier in the video. You can check out the video from the link provided above, tapping the link. So now it is the time we can solve this question paper 2 part 1. In the previous video, I have described it in detail. The marks distribution of the previous question paper and the new upcoming pattern. You can watch it from there. So now talking about question number 1, the long question here that was on stomach. Question was describe stomach under following headings: gross anatomy, then relations, blood supply and the lymphatic drainage, and of course the clinical anatomy. So this is a super important question. You should always prepare it before going for your exams. Stomach can come anytime as a long question, or you may get a part of it like in a short answer question also, like only describing the lymphatic drainage of the stomach. That is important. Now in clinical anatomy of the stomach, don't forget to mention about the peptic ulcers, gastric ulcers, and of course remember that peptic ulcers are more common in blood group O, while gastric carcinoma is more common in people with blood group A. And gastric carcinoma, don't forget to mention about the metastasis through the thoracic duct reaching up to the left supraclavicular lymph nodes, the Virchow nodes, and the Trozier sign. You can also mention about the pyloric stenosis, pyloric obstruction, hyposthenic stomach, hypersthenic stomach. Hyposthenic is long and narrow, which is more prone for gastric ulcers. Hypersthenic stomach is short and broad and it's more prone for duodenal ulcers. You should always give this topic a good reading before going for the exams. Question number 2, write briefly on thoracic duct. These are very important questions. Don't miss them before going for the exams. Thoracic duct, it's the largest lymphatic channel ascending up from the cisterna chyli through the aortic opening in the diaphragm at the level of T12 on the right side of the abdominal aorta, ascending on the right side of the thoracic aorta at the level of T5, just below to the plane of the mandibulosternal joint, that is between T4 and T5. It crosses from the right to the left side, and then in the superior mediastinum it ascends on the left side of the spine, and then it crosses the thoracic inlet, reaching up to the transverse process C7. It curves down and then opens into the junction of left interjugular and left subclavian, where it drains into the left brachiocephalic vein. And don't forget to draw the diagrams. The development of the interatrial septum, super important question. Don't miss this. Have a good knowledge about the development of right atrium, at least right atrium and the interatrial septum and the congenital heart defects, tetralogy of Fallot as well. Then its posterior relations to the right kidney. This also is very important. You'll have to draw the diagrams. And the important thing that the examiner checks out in this is that whether you have drawn the 11th rib or not, because that's the point of differentiating between the posterior relations of right and the left kidney. So because that the right kidney is a little lower down placed, you'll have only the 12th rib in posterior relation. But on the left side, because the kidney is a little higher placed on the left side, so there you'll find impression of both 11th and 12th rib. Rest, of course, the muscles, the diaphragm, and the nerves. Bronchopulmonary segment is also important. Remember the 10 bronchopulmonary segments on both the sides. Draw the diagram and number them in the sequence, which is an international coding. So follow those numbering of the bronchopulmonary segments along with the diagrams. The important line that these BPS are aerated by the tertiary or the segmental bronchus. This is the first and important line you will have to highlight. The apices of these pyramidal segments, they are facing toward the hilum of the lung. Mention the surgical importance of bronchopulmonary segments. That surgical resection of the segments is done along the planes of the tributaries of the pulmonary veins, which are intersegmental. So each pulmonary vein drains more than one BPS. So it should be noted that each BPS is not a bronchovascular segment. Now, helping you solve these MCQs, question number 3, which is about the MCQs, the first one is inability to extend the knee and loss of cutaneous sensations over the anterior surface of the thigh would indicate a lesion or a compression of the obturator nerve, femoral nerve, sciatic nerve, tibial nerve. So they're talking about the innervations of the muscles causing extension of the knee, and that is quadriceps femoris. So all the intrinsic muscles of the front of thigh, that includes the three vasti and the rectus femoris, all of them are innervated by the femoral nerve, including sartorius, including pectineus as well, the anterior portion of the pectineus. Now there's an MCQ here also from my side, that femoral nerve innervates all the muscles of the front of thigh through its posterior division. There are two divisions of femoral nerve, anterior and posterior division. So all the muscles of the front of thigh, they are innervated by the posterior division of the femoral nerve, except one. And that muscle is innervated by the anterior division of the femoral nerve. The muscle is sartorius. So remember that the sartorius is being innervated by the anterior division, and mostly it is through the cutaneous branch, and that is the intermediate cutaneous nerve of thigh. Now another MCQ from my side, the anterior division of the femoral nerve mainly provides cutaneous branches like medial cutaneous nerve thigh, intermediate cutaneous nerve thigh, which reach down over to the patella to form a prepatellar plexus. So tell me, which cutaneous nerve arises from the posterior division of the femoral nerve? And the answer is saphenous nerve. So I hope you've understood this. Not only the muscles, but also there will be loss of cutaneous sensations over the anterior surface of the thigh. So the answer here will be femoral nerve. Next question is, boundary of the triangle of auscultation is not formed by. For this, you should watch a video. I have made it on a cadaver, and there I have described this triangle of auscultation in detail. There you will get to know all the relevant information you need to know about this triangle of auscultation. So the question here is, the boundary of triangle of auscultation is not formed by serratus anterior, scapula, trapezius, latissimus dorsi. The answer here will be serratus anterior. It's a muscle of the posterolateral surface of the thorax, and it inserts onto the costal surface of the medial bord of the scapula. So it is not reaching into the triangle of auscultation. Next question C. Which of the following structure is correctly matched with its remnant? Ligamentum teres hepatis, that is an obliterated left umbilical vein. Ovarian ligament, that's a remnant of vitellointestinal duct. Ligamentum venosum, that's a remnant of gubernaculum. Meckel's diverticulum is a remnant of obliterated ductus venosus. So they have asked is, which is correctly matched? So now look here, ligamentum teres hepatis is of course the obliterated left umbilical vein. Then ovarian ligament is a remnant of gubernaculum. Ligamentum venosum is a remnant of obliterated ductus venosus. Meckel's diverticulum is a remnant of vitellointestinal duct. So you got your answer now? The answer is A. Ligamentum venosum teres is a remnant of obliterated left umbilical vein. Question number 3D. An elderly lady suffers a coronary occlusion. Subsequently, it is noted that there is complete heart block. That is, right and left bundles of the conduction system have been damaged. The artery most likely involved is. That means they are asking about the arterial supply of AV node. I hope you've guessed what they are asking, right? Because they're mentioning that both right and left bundles have been damaged. And right and left bundles arising from AV node to the bundle of His. So, which artery supply is simply, the summary of this question is that what is the arterial supply of AV node? The options are circumflex branch, anterior interventricular artery, posterior interventricular artery, and right marginal artery. So you must know that cardiac dominance refers to that out of right and left coronary artery, that posterior interventricular artery is a branch of mostly around 90% it's the branch from the right coronary artery, and that's why we call it as right-sided dominance of the heart. And otherwise, in this question, it's not relevant whether it's a branch from the right coronary or the left coronary. But remember that the posterior interventricular artery runs close to the crux of the heart and descends down into the posterior interventricular groove. It gives septal branches that perfuses the posterior one-third of the interventricular septum, right? And remember that that's the location of AV node. An AV node, it's situated in the lower and the dorsal part of the interatrial septum that lies just above to the opening of the coronary sinus. So there it's very much in close approximation to the passage of the posterior interventricular artery. So remember that mostly the blood supply to AV node is by posterior interventricular artery. So the answer here will be C. Next question number 3E. When femur is fractured, the broken distal end often turns posteriorly to enter the popliteal fossa due to muscle traction. Because of its position deep in the fossa, which structure is most vulnerable to laceration? Choices are common peroneal nerves, small saphenous vein. They should have written it completely. Small saphenous vein, popliteal artery, and tibial nerve. The purpose of this question is that what is the deepest structure in the popliteal fossa, or what they want to ask is that which structure is in intimate contact to the bone in the popliteal fossa. That's why there are chances of laceration of that structure in case of fracture of the femur. So the answer is very easy, and you know that the popliteal artery is the deepest lying structure in the popliteal fossa, and being so deeply and closely applied to the two bones, both femur and tibia, it has very much chances of getting lacerated in case of fracture or dislocation injuries at the knee joint or above to it. Now question number 3F. Congenital megacolon, that's Hirschsprung's disease, is related to number 1, failure of migration of neural crest cells in the wall of the colon. Number 2, the segment proximal to it is grossly dilated. Number 3, the segment distal to it is grossly dilated. And number 4 is loss of peristalsis. So you have to check out that out of these 4, what statements are correct? 1, 2, 4, or 1, 3, 4, or only 1 and 2 is correct, or only 1 and 3 is correct. Now this question is solely dependent on your knowledge about congenital megacolon or Hirschsprung's disease. So let me tell you a little bit about this Hirschsprung's disease. That of course it's the failure of migration of neural crest cells in the wall of the colon. This number 1 is the correct statement. That is the exact cause, and of course that results to be loss in peristalsis, because the ganglion cells Remember, those are the cells which are interconnecting cells between, the parasympathetic nerve fibers and the smooth muscle cells. So there are Meissner's and Meyenteric plexuses. You must be knowing Meissner's plexus is present in the submucosa. Meyenteric plexus, which also called as Orbeck's plexus, is present between the inner circular and outer longitudinal muscle coat. Now these cells need ganglionic cells to interconnect the stimulus the parasympathetic fibers are conveying there. So in absence of these ganglionic cells, there is no contractile waves in the GIT in that segment, and that leads to loss of peristalsis in that portion of the colon. So loss of peristalsis is of course the correct statement here. Now, if there will be loss of peristalsis in a certain segment of the intestine, let me tell you that this is more commonly in the distal rectum portion. So, obviously, there will be narrowing of the colon below or distal to this segment where there is no ganglionic cells. So because there is no peristalsis, the segment distal to this, the segment of the colon distal to this disease will be narrow in caliber, and because the segment proximal to this, which has lost those ganglionic cells, and of course there will be food collected in that proximal segment, and that will lead to the dilatation of the segment proximal to the Hirschsprung's disease area. So the segment proximal to it is grossly dilated. So your answer here will be 1, 2, and 4 are the correct statements. That is choice number A. Next question, G. Crista terminalis is a feature of right ventricle, left atrium, right atrium. Super important question, because I believe you all must be aware of this, and you must have drawn the diagrams of the right atrium, which is a very important question. The interior of the right atrium, the internal structure. So you all know, you must have seen that there is crista terminalis present in the wall of the right atrium, which is separating the posterior smooth part from the anterior rough part. This shows the line of demarcation that the posterior smooth part is being derived from the right horn of the sinus venosus, and anterior roughened portion being derived from the primitive atrium. And from this crista terminalis, you will find is musculi pectinati being attached. It gives an appearance of a comb-like appearance from the crista terminalis. So crista terminalis is a vertical strip of muscular thickening on the right side of the interior or the right atrium. And remember, on the surface, on outside, it presents as sulcus terminalis. And with this point, sulcus terminalis, you should also remember the location of SA node. Remember, when you talk about sulcus terminalis, on the outside, to the upper limit of the sulcus terminalis, where there will be junction of the SVC. On inside, will you find where this sulcus terminalis joins opening of superior vena cava. That's a point on the sulcus terminalis you'll find is SA node. Next question, H. The diaphragmatic hernia can occur in the following sites except esophageal opening, Bocca-Delex triangle, foramen of Morgagni, IVC opening. So remember that the hernia, generally we talk about the viscera protruding out from their original site. The abdominal contents can easily reach into the thoracic region through these sites. So esophageal opening, of course, hiatal hernia, rolling hernia, lot many things you must have heard about this. So it's a common site for diaphragmatic hernia. Bocca-Delex triangle, remember it's located posterolaterally. It's a gap in the diaphragm because of the pleuroperitoneal communication, which is not blocked sometimes, that leads to a Bocca-Delex gap in posterolateral portion of the diaphragm. So it's the commonest congenital diaphragmatic hernia. Remember, Bocca-Delex is the commonest congenital diaphragmatic hernia. And sliding hernia of the esophageal opening, through the esophageal opening, is the commonest diaphragmatic hernia in adults. Foramen of Morgagni is also called Lery's space, just behind to the sternal attachment of the diaphragm, through which superior epigastric vessels pass down. So there are also chances of herniation, but because IVC opening, IVC opening is in the central tendon of the diaphragm, right? So central tendon, is a fibrous thing. And vena cava also is a fibrous on outside tunica adventitia, right? So this opening is not providing any passage for the viscera to protrude inside the thoracic cavity. And remember that IVC openings also provide passage to the right phrenic nerve. So remember that the diaphragmatic hernia seldom occurs through this IVC opening. And for your information, IVC opening lies at the level of T8 vertebra. Esophageal opening lies at the level of T10 vertebra. Aortic opening lies at the level of T12 vertebra. And foramen of Morgagni, this opening lies at the level of T9 vertebra. Question number I. Which of the following is not related to the superior surface of first rib? Ventral ramus of T1, lower trunk of the brachial plexus, subclavian artery, subclavian vein. So ventral ramus of T1, the thoracic spinal nerves, they emerge out from below to their numerically corresponding vertebrae, while the cervical nerves, they emerge out above to their numerically corresponding vertebrae. Means like C6 will emerge out between C5 and C6, C7 will emerge out between C6 and C7 vertebrae. But thoracic, lumbar, sacral onwards, down below from T1 onwards, the spinal nerve emerges from below to the numerically corresponding vertebrae. And the reason is you have 8 cervical nerves and 7 cervical vertebrae. So 8 cervical nerve emerges from below to C7 and above to T1. That means intervertebral foramen between C7 and T1 vertebrae. So that means we are talking is about now here choice number A, that is ventral ramus of T1. So as soon the spinal nerve of T1 is actually a content of superior mediastinum because it is emerging below to T1 vertebrae between T1 and T2. So as soon it emerges, it divides into two ramus, a ventral and a dorsal ramus. And you know that ventral ramus of C5 to T1 participates in the brachial plexus. But here, because we have thoracic intercostal nerves as well, and these intercostal nerves are also the ventral ramus of thoracic spinal nerves. So what happens in case of T1 ventral ramus, it splits into two divisions, a minor and a major division. The minor division of ventral ramus of T1 continues as the first intercostal nerve. Then the major division of the ventral ramus of T1 participates in the brachial plexus. It joins the ventral ramus of C8 to form the lower trunk of brachial plexus. Now this is happening before it reaches to first rib. So onto the upper surface of the first rib, it is the ventral ramus of C8 and T1 that joins to form the lower trunk of brachial plexus, and the lower trunk itself crosses the upper surface of the first rib. Right? So the answer here is which of the following is not related to the superior surface of the first rib? Remember that the ventral ramus of T1 does not crosses the upper surface of first rib. It's a lower trunk of brachial plexus, subclavian artery, subclavian vein. These are the structures which cross the upper surface of the first rib. And remember, subclavian vein is anterior most, which is separated by the subclavian artery by an scalene tubercle present on the inner border of the first rib, which provides insertion of scalenus anterior muscle. And behind to that is subclavian artery and lower trunk of brachial plexus. And both these structures, subclavian artery, lower trunk of brachial plexus, they will be covered by a extension of prevertebral fascia called the axillary sheath. Next question is 3J, the last one. The parietal pleura is insensitive to pain, dips into the lung fissures, is attached adherently to the lung surface, joins the visceral pleura at the hilum of the lung. So the parietal pleura, is derived from the somatopleuric layer of the intraembryonic mesoderm. So it is pain sensitive and is innervated by the intercostal nerves, and it does not dips into the lung fissures, and it is not adherently attached to the lung surface. Rather, you can say that A, B and C choices are the features of the visceral pleura. This visceral pleura is derived from the splanchnopluric layer of the embryonic mesoderm. So it is being innervated by the autonomic nerves and it is pain insensitive. It dips into the lung fissures and is adherently attached to the lung surface. While talking about parietal pleura, remember that it joins the visceral pleura and the hilum of the lungs. So answer here is choice number D. So here we are done with paper 2 part 1. Now we will be discussing anatomy paper 2 part 2. The same marking pattern is here also. Talking about question number 1, that is describe hip joint under the following headings. Structure and ligaments. You have to enumerate all the ligaments. Then movements with the performing muscles. Of course, all the movements there at the hip joint, because it's a ball and socket variety of joint. All the movements permissible: flexion, extension, adduction, abduction, medial rotation, lateral rotation. You have to mention all the muscles performing these actions. While talking about the structure, you have to define the acetabulum, the head of femur, the capsule, and the weaknesses and the strength of this joint, and the most stable position of the joint, most unstable position of the joint. Right, and talking about clinical anatomy. In the clinical anatomy, you'll have to discuss the most commonest site of dislocation, the posterior dislocation. Why is it common? Then congenital dislocation of the hip, tuberculosis of the hip joint, right? Then coxa vera, coxa valga. Don't forget to mention, even if not asked, the blood supply of the hip joint can be mentioned while writing about the structure of the joint. Then fracture neck of femur, right? Fracture head of femur, intra-articular fracture, hemarthrosis, hip replacement, total hip replacement, and you can also mention about the Trendelenburg test, right? If there is intra-articular fracture of the neck of femur, there may be chances of limb lengthening, right? So you can mention about all these facts and what will be the position of the lower limb in fracture neck of femur. All the relevant clinical and anatomical points you can mention, you can write here. So this is a long and an important question. Make sure you prepare this question very well before going for the exams. Then question number 2, write short notes on popliteal fossa. It's a super important question. Rhomboid shaped fossa present in the posterior relation to the knee joint, right? The supralateral, supromedial, infralateral, infomedial boundaries, the muscles forming the roof and the roof of the popliteal fossa, contents of the popliteal fossa, floor of the popliteal fossa, the blood supply, right? Anastomosis around the knee joint, all the relevant facts you can mention here. Then Baker's cyst, Brody's abscess, these also can be mentioned here in the popliteal fossa. Don't forget to mention about the laceration of popliteal artery that we have discussed in the MCQs earlier. Then question number 2b, internal features of the right atrium. This again is a very super hit important question. You must be prepared with this question before going for the exams. Supports of the uterus, super important question. Every undergraduate must prepare these questions before going for the university exams. All the supports, primary, secondary supports. Then histology of testis. Remember, one question on systemic histology has to be there in paper 2. So you should also be prepared with all the histological slides of the viscera of the abdomen, pelvis, and thorax while going for paper 2. So histology of testis is important. Make sure you prepare this before going for the exams. 1, 2, and 3 MCQs now. So the first MCQ here is afferent pain fibers for the biliary tract do not respond to distension of the viscus, run with the vagus nerve to the nucleus of the solitary tract, may run with the right phrenic nerve, run with the spinal nerves to T2 to T5. You have to select the correct statement. Remember that this nerve supply to the gallbladder and the biliary system is very important, because in one of the universities earlier also this question was asked about the referred pain of cholecystitis. That also is somewhat relevant to this question here. So this is about the nerve supply to the gallbladder and the biliary apparatus. Remember, the nerve supply to the biliary apparatus is by both right and left vagus, and the right phrenic nerve, as well as the sympathetic nerves. Sympathetic nerves from T7 to T9 segments. Then all of them, from the celiac plexus, these nerves reach to the hepatic plexus, and from the hepatic plexus, these extend to supply the gallbladder in the form of cystic plexus. So from the cystic plexus, remember the nerve supply to gallbladder is by the three nerves I have already told you: sympathetic, parasympathetic, and from the phrenic nerves. Parasympathetic nervation to the gallbladder and the biliary apparatus act on the smooth muscles and are motor in supply. So they cause for the contraction of the musculature of the gallbladder and the biliary apparatus. But remember, these are inhibited to the sphincters. And what causes contraction of the sphincters is the sympathetic supply, that is from T7 to T9 segments. The sympathetic supply is actually acting upon the sphincters, as well as the sympathetic supply is also vasomotor, causing vasoconstriction. Just because I talked about the question being asked earlier, that was regarding to the radiation of the pain of cholecystitis at the three sides. Remember, if the pain radiates through the vagus nerve, it will radiate to the epigastric region. If the pain is conveyed through the sympathetic fibers, then it will be radiating to the inferior angle of the scapula on the right side because of the involvement of T7 spinal segment. And if the pain is being conveyed through the phrenic nerve, it will be radiated to the apex or the summit of the right shoulder, because that's the territory of C4 spinal segment. The somatic dermatomal area of C4 is on the upper portion of the shoulders, and phrenic nerve is related to C3, C4, C5 spinal segments. So that's how the pain from the gallbladder can radiate to the three sides: epigastrium through the parasympathetic, that's vagus. Sympathetic relay radiates it to the inferior angle of the right scapula, and through phrenic it reaches to the summit of the right shoulder. Choice number A, that afferent pain fibers from the biliary tract do not respond to distension of the viscus. This is somewhat related to the Courvoisier's law. I hope you know what's Courvoisier's law. That is that the dilatation of the gallbladder, if it occurs only due to extrinsic causes like obstruction of the bile duct because of the pressure of the carcinoma head of the pancreas. So the Courvoisier's law states that the intrinsic causes like obliteration because of the gallstones is not the actual cause for dilatation of the gallbladder, because that eventually leads to fibrosis. So the dilatation of the gallbladder occurs only in extrinsic obstruction of the biliary apparatus. So whatever may be the cause of distension of gallbladder, remember that the distension of the gallbladder is pain sensitive. So the afferent pain fibers do respond to the distension of the viscus. So after knowing all the facts about the pain fibers from the biliary tract, we got to know that the spinal segments T2 to T5 are conveying sympathetic innervation to the head and neck, thorax, and the upper limbs. Remember, the greater splanchnic nerve was from T5 to T9, that was descending down to the crest of the diaphragm into the abdomen, and the lesser splanchnic nerve is from T10 to T11 spinal segments, that also descends down into the abdomen by piercing the crest of the diaphragm. The T12 spinal segment gives the least splanchnic, also called as renal nerve, which reaches down to supply the renal plexus, while the greater and lesser splanchnic nerves descend down to participate in the celiac plexus, right? And from celiac it goes to the hepatic plexus, then to cystic plexus, and that's how it innervates the gallbladder. So according to me, afferent pain fibers to the biliary tract do not respond to the distension of the viscus is wrong. As I told you, after a certain limit, the distension of the viscus becomes painful. The next is, it runs with the vagus nerve to the nucleus of the solitary tract. This also is wrong because the vagus does carries general visceral afferent sensations, the pain sensations from the viscera in the head and neck region, to be relayed in the nucleus tractus solitarius in the lower half, in the lower portion of the nucleus tractus solitarius, because the this nucleus is a combined nucleus. So In the upper portion of the nucleus tractus solitarius, there are special visceral afferent sensations being received from the tongue, the taste sensations. While in the lower portion of the nucleus tractus solitarius, the general visceral afferent sensations, touch, pressure, pain from the viscera of the head and neck region is being relayed by all the nerves. The lingual nerve, the glossopharyngeal nerve, the vagus from the vallicula, from the epiglottis, soft palate, pharynx. But the pain from the lower extremity means below to the neck, like pain from the viscus in the thorax, in the abdomen, pelvis, lower limbs, right? So from there, the pain is being conveyed by the sympathetic, parasympathetic, vagus also. But this pain from the thorax, upper limb, abdomen, pelvis, lower limbs, the general visceral afferent sensations, including the pain sensations, are relayed firstly into the thalamus in the ventro-posterolateral nucleus and the ventro-posterior-inferior nucleus of the thalamus, right? And from there, the next order neurons, they convey these sensations to the higher cortex, the primary sensory cortex. So remember that vagus carries pain sensation from the head and neck region to the lower portion of the nucleus tractus solitarius, not from the biliary tract. So choice number B is also wrong. Then choice number C may run with the right phrenic nerve. This is correct because the right phrenic nerve, as I told you, does participates in the celiac plexus, also participates in the hepatic plexus. Via hepatic, it reaches the celiac plexus or directly also. And it does involves in conveying pain sensations from the gallbladder. As you must have commonly heard that the pain of cholecystitis is radiated to the right shoulder, and that is the region of C4 territory, the dermatome of C4, which is the same segment from where phrenic nerve arises. C3, C4, C5 is the root number for phrenic nerve, right? So choice C is correct in my opinion. However, choice D, which says that the afferent pain fibers for the biliary tract run with spinal nerves to T2 to T5, is wrong. As I already said that the spinal nerves T2 to T5 are involved with the innervation of thoracic head and neck region. If you talk about the sympathetic innervation from the lateral horn of these spinal segments. So if choice D is related to sympathetic fibers, then remember that the pain of cholecystitis or from the biliary tract is conveyed via spinal nerves from T7 to T9 spinal segments. And that's why you must be knowing that the pain of cholecystitis radiates to the inferior angle of the right scapula, which overlies 7th intercostal space or the 7th rib. So I will go with choice number C, that the afferent pain fibers for the biliary tract may run with the right phrenic nerve. Although this question was a bit tricky, I would say it was not of undergraduate level. But anyhow, remember that knowledge never goes wasted. So whatever fundas, whatever concept we just talked about, I told you so many important facts about this innovation of the biliary tract. All the knowledge is really important and it will help you in your further exams. Question number 3b. The vena cava opening in the diaphragm lies at the level of T12, L1, T10, T8. This I have already explained in somewhat similar MCQ in paper 2 part 1. Remember that the vena cava opening lies at the highest level of the dome of the diaphragm. There is the central tendon of the diaphragm which has this opening, and that lies at the level of T8 thoracic vertebra. Answer is D. Esophageal opening, remember, lies at the level of T10 vertebra. Aortic opening lies at the level of T12 vertebra. And foramen Morgagni, the Laries space, that lies just behind to the xiphisternum, and that lies at the level of T9 vertebra. 3C. Which of the following nerves innervate the costal pleura? Vagus, intercostal, splanchnic, phrenic. This also I have explained in one of the MCQs previously discussed in paper 2 part 1 regarding pleura. So remember that the costal pleura is a part of the parietal pleura. We have different names of the parietal pleura according to its location. We have costal pleura adjacent to the ribs, then diaphragmatic pleura overlying to the diaphragm, mediastinal pleura covering the mediastinal surface of the lungs, and a cervical pleura which is protruding above to the first rib into the neck. So these are the different names of the parietal pleura according to its location. So talking about the costal pleura means we're talking about the parietal pleura lying below to the rib cage. And I told you that it is pain sensitive also. It does not reaches into the fissures of the lungs. It is not adherent to the lung surface, and it is innervated by intercostal nerves. Answer is B. Question number 3D. The great saphenous vein is a continuation of the lateral marginal vein of the foot, runs between the two heads of gastrocnemius, pierces the cribriform fascia at the upper thigh, can be found immediately below and lateral to the pubic tubercle. So the answer here is C, that it pierces the cribriform fascia in the upper thigh. It is around 4 to 5 centimeter lateral and below to the pubic tubercle. So choice number D is not correct, as it's saying that it can be found immediately below and lateral to the pubic tubercle is wrong, because there immediately below and lateral to the pubic tubercle is superficial external pudendal vein, which is a tributary of great saphenous. So the answer will be C. And cribriform fascia is a weakness in the fascia lata, that's a deep fascia of the thigh. So through this cribriform fascia, great saphenous vein goes inside and drains into the femoral vein. Question number 3E. Derivative of the paramesonephric duct is testis, fallopian tubes, paraoophoron, oophoron. So remember, paramesonephric duct is also called Mullerian duct, which helps to form fallopian tubes, uterus, and the upper one third of the vagina in females. And mesonephric duct is also called Wolffian duct, which forms the ejaculatory pathway of the semen from vasa efferentia, epididymis, vas deferens, seminal vesicles, ejaculatory ducts. All this is being formed by the mesonephric duct or Wolffian duct. And the remnant or the degenerative portion of the mesonephric duct in females are these paraoophrons and oophrons. So remember, M for male, M for Mullerian duct is not happening. Mullerian duct is forming the female reproductive system. W for woman, W for Wolffian duct is not happening. Wolffian duct is forming the ejaculatory pathway in males. So the answer here is fallopian tubes. Then question number 3F. The first part of duodenum lies at the level of L2 in the supine body, is approximately 10 centimeter long in length in an adult, partially overlies the right crus of the diaphragm and psoas muscle, is entirely retroperitoneal. So let me tell you about the important points regarding the first part of the duodenum. Firstly, it is overlying to L1 vertebra in the supine body, not L2. So your choice number A is not correct. Then it is 5 centimeter long in length in an adult, not 10 centimeter. So it also is not correct. And here I am going to tell you the entire length of this duodenum, which is actually 25 centimeters somewhat. So its first part, is 5 centimeter. Second part is 7.5 centimeter. Third part is 10 centimeter. And the last one, that the fourth part, is 2.5 centimeter. That makes it 25 centimeter total, and that is equal to around 10 inches in length. So out of that 4 parts, the longest one is the third part, which is 10 centimeter, and the shortest part is the fourth part, which is 2.5 centimeter. But this first part is not 10 centimeter, it is 5 centimeters. So your choice number B is also wrong. Then out of this 5 centimeter, the proximal 2.5 centimeter is mobile. It's not a retroperitoneal. It is attached to the lesser omentum in the form of hepatoduodenal ligament, while the distal 2.5 centimeters, which is in continuation with the second part, is retroperitoneal. So it is not entirely retroperitoneal. Proximal part is covered by peritoneum. The distal part is retroperitoneal. So choice number D is also wrong. Lastly, you're left with the choice C, that is partially overlies the right crest of the diaphragm and psoas muscle is correct. Not true about right bronchus is shorter, wider, more horizontal in the line of trachea. It's easy because you must be knowing about the bifurcation of the trachea into right and left principal bronchus at the level of the manubrosternal joint just below to it, or the vertebral level is transverse plane passing between T4 and T5 thoracic vertebra, where this right principal bronchus is more in alignment with the trachea. It's less deviated towards the right and it is shorter and wider, while the left principal bronchus is more angulated, is more tilted towards the left side. It is longer and narrower. So not true about the right bronchus is that it is more horizontal is a wrong thing. It is more horizontal is actually the left principal bronchus. So the right principal bronchus is shorter, wider and is in the line of the trachea. Question number 3H. Mediastinal surface of the right lung is related to all except right atrium, arch of aorta, arch of azygous vein, inferior vena cava. So you know that the right lung on its mediastinal surface is related to the right surface of the heart, means right atrium. And the right atrium down below is continuous with the inferior vena cava. So you will find is the impression of right atrium, inferior vena cava, including the impression of superior vena cava also. And you also find is the arch of azygous vein draining into the SVC or the superior vena cava. So arch of azygous vein will also be seen in relation to the mediastinal surface of the right lung. It actually arches over the hilum of the right lung. What they have asked is all except. So remember the answer here will be B choice. That arch of aorta actually is seen in relation to the mediastinal surface of the left lung. It arches over to the hilum of the left lung. Question number 3I. All are true about popliteus except is a flexor of knee, has intracapsular origin, is supplied by tibial nerve, it causes locking of knee. So regarding popliteus muscle, remember it is a weak flexor of the knee. Of course, its origin is from the lateral surface of the lateral condyle of femur, which is intra-articular or intracapsular in origin, has a tendinous origin and a fleshy insertion behind to the tibia above to the oblique line on the posterior surface of the tibia. And of course, it is supplied by tibial nerve. All are true about popliteus except. So remember, it causes unlocking of the knee joint. It's a key muscle for the knee joint. It unlocks the knee joint while you are standing on the floor. It actually rotates the femur laterally, causing the medial condyle of femur to be brought out anteriorly from the medial meniscus. That's the lateral rotation of femur over to the fixed tibia is actually unlocking, which is being done by the popliteus. By locking muscle, if they ask which muscle causes locking of the knee joint, then it is vastus medialis. Last question here is 3J. Structure crossing dorsal surface of ischial spine are all except internal pudendal vessels, pudendal nerve, sciatic nerve, nerve to obturator internus. This question you should know that there were four structures which are emerging out from the greater sciatic foramen below to the piriformis, and they were crossing the ischial spine, also the sacrospinous ligament, and then reaching back into the pelvis to the lesser sciatic foramen. And those four structures were the pudendal nerve, the internal pudendal vessels, and nerve to obturator internus. All these structures you can see they have been mentioned here as choice number A. Internal pudendal vessels means internal pudendal artery and vein. Then you have pudendal nerve and nerve to obturator internus. They are seen into the gluteal region only for a short while, and that is crossing the dorsal surface of ischial spine and the apex of sacrospinous ligament. Actually, pudendal nerve does not crosses the dorsal surface of ischial spine. It actually crosses the apex of sacrospinous ligament, which is attached to the tip of the ischial spine. So the answer here is sciatic nerve. Sciatic nerve also emerges into the gluteal region by passing out through the greater sciatic foramen below to the piriformis. It is a very thick nerve, in fact the largest nerve of the human body. It descends down into the back of thigh, but it does not crosses the dorsal surface of ischial spine. So the answer here will be sciatic nerve, choice number C. So that's how I've completed all the four parts: anatomy paper 1, part 1, part 2, anatomy paper 2, part 1, part 2. All have been discussed, but remember the long and short answers I have not discussed in detail. I have just given some important points, but you'll have to study all these important questions from the book. And MCQs have helped you to reason out the choices, so that gives you an idea to solve similar MCQs later on. Okay, good luck guys. Wish you all the best.